brought up something I think is really kind of key here, and it's a term maybe not everyone who has the opportunity to take a look at this will understand. It's concierge medicine. And that I find it really interesting. It's a very boutique kind of name.
It sounds boutique. I know it sounds bougie.
It does. It absolutely does. But I find it really interesting, despite the bougie name, is it kind of harkens back to a Marcus Welby, if you will, if anybody out there knows that. It's the, docs going back into the home, caregivers going back into the home. And yes, we're talking wound care currently, but I think we're at a point where we're going to be seeing a little bit of a revolution here in medicine, where what is old is new again, and we're going to see this, I think, transfer not only from wound care but into other areas of specialty, and we're going to see more of this happening. What are your thoughts on that? Are you hearing from maybe some of your colleagues who are not in wound care but watching what you're doing, asking some inquisitive, type, hey, how'd you do this? How's it work? How can we make it work over here? Are you hearing anything like that?
Well, I used to be, even when I was in private practice, I used to make house calls for general podiatry care. And there is a very large network of visiting physicians in my area, and they were kind of ahead of the curve in this as well. But yeah, I think it's going to affect all aspects of medical care and treatment. I mean, we know that home health care does it, physical therapy does it, PCPs do it, wound care, is a growing field that's going into the home. So I do think that we're going to see more of this, and it may be via telemedicine, like Des brought up, and where a PCP or internal medicine doctor has several nurse practitioners, and they could kind of be the top of the pyramid, and then all the nurse practitioners or RNs go to the home, assess the patients. Then you have that consultation via telemedicine, and there's that continuity of care, and again, that patient is not displaced, and they don't have to worry about getting the ride to the doctor, and they don't, deteriorate and end up in the hospital. So I do think that this is a model that will really be far-reaching in all aspects of medicine via telemedicine and telehealth, even remote patient monitoring, which is something we can discuss as well. I mean, I think it all marries together. They're all pieces of a puzzle we're trying to solve as our patients get older, and our patients have many comorbidities, and our patients want to stay at home.
Well, yeah, the remote patient monitoring, I brought up a few years ago to a guy who had a clinical trials company, and rather than go to the places, so I said, well, Apple Watch is going to be the future of that. And he poo-pooed me. Well, Apple Watch is going to be the future of that, because they figured out that it's not a watch. First of all, anybody my age, anybody over 40, and I don't know how old you are, anybody over 40 can have an Apple Watch. If you got to do that and put on glasses to read your damn watch, then what the hell benefit? Yeah, why do I want the damn watch? So the deal with the watch, though, is that they're going to be able to do O2 sats, blood pressure, sugar, pulse, your rhythm. And apparently, you turn it around and put it over your radial artery, they're going to be able to measure your BUN and creatinine and everything else with a little thing that goes down. I mean, it's going to be crazy. And that's going to be a wonderful thing, I think.
Yeah.
Probably
monitoring,
get your A1C.
Well, they've been doing, congestive heart failure patients have had access to the CardioMEMS program now too for a while, where it's remote monitoring. So every time they start to retain fluid or whatever, their physician is notified. Their cardiologist gets the call, and instead of having to bring them into the hospital and diurese them, now they're able to intervene or tell them what to do. More and more of these things will be apparent. And I think it all goes back to everybody would rather be home. And, I don't know if, I'd like to touch a little bit too about some of the, the cultural differences too that we see. And have you all experienced this in your careers too, where, whether it's ethnic groups or people in general just have an attitude that they don't want to put their loved one in a facility?
Well, don't you think it was evolutionary from when Randy and I always talk as the elder people, my dad gave me the directive that I would take care of my mom and keep her in her residence until at which point I deemed it wasn't possible. So we tried, but it was actually miserable for her because she was in her house with people that would come in and out, but no social interaction. And she was very social.
Yep.
And then,
Yep.
and then my in-laws had the grandmother, when I first got married, Elizabeth's mother stayed there, and they built a place off the back of the house, and she lived with them for, like you said, 25 years. And then I feel like we've evolved into this. Well, and the end of my story is, so when my mother-in-law, who just passed away at 96, when she saw what happened to my mother after my dad died, as soon as my father-in-law died, she immediately moved into you get a house and an apartment, then you go to skilled, but where you buy into the whole kit and caboodle. And it worked very well for her. Now, the only thing I have now, when you talk like what Wendy was talking about with their mother, it's the cost, because at some point, unless people have this fancy insurance, they go through their Medicare money and then they end up on Medicaid. And no matter what your status, it's very expensive. And if you go to a nursing home and live another 15 years, you run out of dough.
Yeah.
So,
and then your care, the quality of care and your surroundings is impacted big time. I mean, we've seen the Medicaid beds versus the private insurance or Medicare beds, and there's a world of difference.
I think the median, I read just in preparation to having this discussion, is about $5,000 a month, and that's a median, and that's for just standard care. So we're not talking about memory care or services. So that's a lot, and some insurance companies, like you said, pay for it and most don't. Some long-term care plans do offset some costs, but people don't necessarily have the forethought to plan it and have these long-term care plans. And, the home care, when my boyfriend's mother was in the home, I mean, that was all just fee for service. And that was very costly. It was costing them, $9,000 a month to have 24-hour care for her, which is what she needed at the time. But it she has a lot of resources, which she's very lucky, but not many people can sustain that.
The other thing with the long-term care, Wendy, was my mother-in-law had that, but then she lived in that setting for so long that I think they average out that they think it's usually the females. Sorry, Des, you and I'll be in the dirt. It's usually females, but they average like 7 or 8 years. So if you live like what you were saying, if somebody lives and develops Alzheimer's and lives to 95, 96, 97, you can be in that setting for 15 to 20 years. So you're going to run out of that because the secondary insurance, I don't know. And it was expensive. I think now at my age, I've looked at it. It was like getting personal disability insurance. It's very expensive. And you have to say, is that worth doing? You have to weigh those dollar amounts as a family.
One of the things, we've talked on, Alzheimer's patients, and that's a special category in a sense too, because a lot of times their body is still pretty good. Their heart is still strong. But they, the mental deterioration puts a tremendous strain on the family, especially if you're trying to keep these people at home. And that is so disruptive, because now we live through this. Nobody in the house gets a good night's sleep anymore, even if you bring in somebody to kind of sit for them eventually. But it's a painful decision to even have to make to put your loved one into a facility. So this is not easy. This is it's not only the patient is impacted, but the support system, the family, the friends. It's very difficult. There's Rick, you touched on something too. That lack of socialization. Sometimes it may be better for that person to be in a setting where there are other people around too. And you got strangers coming in the house, work servicemen or whatever, repairmen or whomever. And if that person's alone, that's a concern. If they're not eating properly, you don't know what they're, what they might be consuming. That's an issue.
I think the nutrition, I think that's
a big one.
Yeah.
something that needs to be revisited because, luckily there are Meals on Wheels and other services, Meals for Mom and other services out there but most patients that live alone, and you probably talk to patients, especially when we're dealing with wounds, what do you eat, what's your protein intake, and you're trying to educate them on what they need to ingest to help to heal. And, I had one little lady tell me, oh, I ate a handful of jelly beans and some toast. That was what she ate, all day.
Yep.
Well, that's not very good. And she lives alone. She doesn't cook or, and maybe we don't want them to cook because an open fire can lead to so that nutritional issue is huge.
Oh, the nutrition stuff was crazy huge. We talked about this before. I can't remember if it was Rhonda or Des, where we started referring people to like Sam's Club or ever, because all those protein drinks that they advertise are like 10 grams, and the one Premier or whatever is 30 grams to the same size, and they were cheap. You get them at, all the big box stores. And so we started trying to get the patients to go get those, just to get some good calorie source in them. But
yeah, it's this vicious cycle. They a lot of times they're on fixed incomes, so they're not going to eat properly. And I don't know if you all have seen this too over the years. None of my patients with wounds had normal nutritional indices. They're always lacking in protein, or their albumin, or anemic, iron binding. All these different things that are important for wound healing would be, not conducive to healing. And they could even be really big people too, which is a whole nother thing. But the point is, nutrition is often one of the first thing that, if somebody's living by themselves, and they're unable to get out very much, their nutrition is gonna be one of the first things that's sacrificed.
Yeah.
And I think their appetite decrease as you age.
Yes.
Seems in general, appetite decreases. So, there's not that drive to have a full, with a good healthy protein and, vegetables, and it's just whatever they can grab that's easy and convenient because their appetite isn't what it used to be.
That's an important point too, for sure.